So if you add anything to the laser, they started calling it
Patient
hybrid. So
has
there's
been
a lot of
taken in the
confusion.
first OT. A patient of 21 years old, MRD 272036, diagnosed with pilonidal sinus, presented with complaints of pain in the natal cleft region since 1 month with opening, has a past history of Krigler-Najjar disease. On examination, opening in natal cleft is seen. On investigation, CT sinogram suggestive of pilonidal sinus tract extending from the gluteal region at S3 S4 level with a blind end in the rectococcygeal region. No evidence of communication with sacrum and coccyx. It's a surgery of MIPH and piles performed by Dr. Nitesh Jhavar. The patient has been induced and draping has been done.
Thank you so much. I would like Dr. Jainam Shah to felicitate our moderators of previous session.
Hello, OT, is this hemorrhoids or it is pilonidal sinus?
Ahmedabad anni. Arey wah.
The case which has been
Okay, cool.
shown on the
Good.
PPT is actually of the pilonidal sinus, but in OT1 we are ready with hemorrhoids.
Yeah. I don't know if I can talk to them directly.
Dr. Nitish is his mic is on and he'll go through the process as
So Nitish,
we
what are you
proceed.
showing? Please tell us. There's some confusion here.
Fine.
Ma'am,
Can we have a
there are-
little head low, please? And bring it. Okay, give me 2 towel clips. Just head low. Bring the table down a bit.
I would like
One more towel
Dr.
clip, please.
Jainam Shah to felicitate our moderators, Dr. Shekhar
towel
Saradkar,
clip.
sir,
I
Dr.
want a
Vinit
towel
Chopra,
clip.
sir,
No.
and Dr. Rajesh
Yeah,
Shukla,
thank
sir.
you. Yes, got it. All right, so we are all set. Fine. Give me a no, this thing. Proctoscope here. This one I need. Yes, on this side we have a little bit, and this thing comes up. Very nice. Good. All right. So am I audible?
Yes,
Yes,
sir,
you
you
are.
are
Yes, you
audible.
are.
We are
Right.
inviting
So
next batch of
I'm sure you must have
moderators.
got the history. Can you give me a single gauze, please, on alleys like this? Right. So before we start, I always insist when we are doing this thing, MIPH or any other hemorrhoid surgery, it is important to take this stock of the situation. So 2 things which I emphasize on. One is you take the stock of the situation first. Second, you start with the end in mind. So what I'm going to do here is called a Sparks maneuver. I'll push a dry gauze inside and then bring it out to assess the prolapse in different areas in relation to the clock, whether it is more at 11, 3 or 7. So here we can see that the one of them is a winner hands down, and this is coming absolutely too much outside. One more important consideration which we should have is to know what is the patient's expectation at the end of it. Now, good thing is when you see people, yeah,
I would like Dr. Kumkum Singh, Dr. Sanjay
fine.
Shingla, and Dr. Hitesh Chavda, sir, to
So I
please
was not
do the
audible all this
honor
while, I
and chair the
assume.
session and moderate us. Thank you.
It is dangerous. Give me 3 Alice, maybe 4. I will need 2 more. Dr. Ritu, can you hold it, please? 2 more. Can I speak? Yeah. So I'm being assisted by Dr. Ritu, who is a senior registrar here in Civil Hospital, and Dr. Nupur. She has traveled all the way from Mumbai to assist me in this case and has kindly agreed to do that. Thank you so much. So as I told, we are going to start with the end in mind. So what I'm trying to do right now is to stabilize the anal verge. Now, most of the time when we do staplers and if we lose the orientation in terms of anal verge, then it can create problem. Now, if you look at this 11 o'clock bile mass, definitely it is not going to respond to only stapler. So sometimes we have to resort to do a modified procedure, some kind of a hybrid technique. Now, till I get my act together, what I have done is I've just put a gauze inside in order to prevent any edema which it can cause. All of you are well versed with the various parts of the stapling device which we use. Give me a faucet, please. So, first thing is to do the dilatation. Now, this dilatation, all of us know that the loss dilatation has largely been given up. But when you are operating a reasonable dilatation, you have to do. And in males, if you're doing it, you can do a dilatation by using your two fingers anteroposteriorly. So this is how you will do the dilatation in the male patient. In female patients, we don't want to damage the sphincter at 12 o'clock position, so it goes sideways. Now, important thing is that this particular thing, circular anal dilator or CAD, should glide easily. Now, what I have deliberately done, that I have not caught hold of this hemorrhoidal tissue which was there at 11 o'clock, because at the end of the procedure, I want it to go inside completely. Now, second important thing is to mount this thing, CAD, on this. And once we do this, it should glide easily. So we have stabilized the anal wash. There is a extended lithotomy position given. And then you just nicely go inside and fix it here. So when I say fix it here, at this particular time, we can let go of these holes which we have at the anal verge, and now we have to fix the CAD in place. Very important thing which I have told, and I keep on telling people, Dr. Nupur and Ritu both, their job is to not to rely on the sutures which I take to fix it. They have to hold it in such a way that I can easily take sutures, one. Secondly, it should not slip at any time. Once I remove this opaque obturator, the second thing which goes inside is a purse string anoscope, PSA, we call it butterfly also. So you get a clear-cut orientation where it is placed. Now we can see that it is much above the dentate line. We can see the dentate line by the side of it. We have gone almost at the hilt of the hemorrhoidal tissue. And when I'm suturing, I don't want this particular hemorrhoid to swell up more, so I'm packing this area using gauze. Now the second step is to take the stitches to fix the CAD, and we can do it in two ways. Either we can do it at the beginning of the procedure where you leave some stay sutures and thread them through these windows which are provided, or you can take it afterwards. Now, rather than keeping that opaque thing inside obturator, if you can give them this posting endoscope to hold, no, don't let go of the other side. Both the things balanced all the time. So this is like, it makes the assistant's job little easier, and you can fix this particular thing. Now, important thing which I am re-emphasizing, I usually don't rely, and nobody should, on these stitches to keep the CAD in place. It is always your assistant who is more important. Yes. So sometimes you may find it a little difficult to take these stitches. Some people take it with those needles which are then you thread a linen on it and do it. So those needles usually create problem. This one is little easier to do, but I'm still finding it difficult. Just in a minute, I think we should be able to do that. Sister, can you give me a forceps, please? I'm not able to direct the needle. Tooth, fine, thank you. So once we fix that, that set the stage for the procedure, and when that is done, we'll go through the, don't tell me I can't take it, wait.
Nitesh, it's a good idea to go from inside out.
I think so, that can work here. Let me see. But this will be a reverse bite. I think I'll just try one more time and see, because I've gone through. Only thing is I'm finding it to come out. Yes. But that's a very good suggestion, sir. Thank you. I'll keep in mind in next two remaining windows. Okay, so when we are doing this, I mean, this does not need any more explanation. If you have any questions, you can put it to our moderator, Dr. Prajul, and he will, put forth to me, and then probably we can have a discussion on this. So hold this.
Anybody
across,
having questions can
across,
write on a small
yes.
slip and send to us.
Yeah, across.
For you.
Hold it like this. Yes. So now I'll follow Dr. Shingla's suggestion at 12 and 6 o'clock position. Probably I'll go from inside out. Now, if you take these stitches beforehand, it is a lot easier to just thread it through. But sometimes I find that if you need to do any alteration later, then we don't have that facility in that particular technique. So it is better to fix it like this. That is my preference, but you can do whatever you like. The idea is to just fix it at 4 places so that if your assistants give way, let go in between, then this should not shift. That's the whole thing. Now, fine. Cut it, please, Dr. Nupur. Yeah, fine. So now give me the thread, please, the suture which comes with this device. So what stapler I'm going to use today is a Merrill stapler. It has got 2 rows. Nowadays, we have one available with 3 rows also. And the good thing about this stapler is the housing's volume is the same. So whether you're using a 2 rows or a 3 rows, the volume of the housing of the stapler, where it is going to take the donut which you remove, is going to be 14 cc. So that's a big advantage because you get good hemostasis by using these triple row staplers. Now, when we look at the thread which comes with this particular thing is a proline. So it glides nicely. Yes, thank you. And first of all, I'm just removing the memory of this so that, this memory goes and it is quite straight. What I prefer doing is taking a belt loop or a counter stitch at the opposite side of the beginning point. So you can divide this thread by 2/3 and 1/3. Take a longer end to finish the first string, smaller one to give you a counter traction on the opposite side. Sister, give me a mosquito, please. And a scissor. Cut it here. Thank you. So at 2 points, I'm going to keep it here. One is on the left side of the patient, on my right side. And the remaining thing, I'll just fix the end of the suture again to the linen on this side. In order to see, it is important when we are doing stapling surgery is to not to lock the first string. That is one of the most important thing. Your assistant should be watchful. Even your nursing staff should be warning you if you go haywire in that case. Preferable to use a longer needle holder so that you can go around 4 centimeter above the dentate line. And this bursting endoscope will definitely help you in assisting that. Now what I'm going to do, can we get a little more head low, please? I would now start, see, usually for a right-handed surgeon, it makes more sense to start at 9 o'clock because 9 to 12. Am I audible? Yeah. So now
Yes,
the
you're
thing is,
audible.
now the thing is that when we start this, for a right-handed surgeon, it is important to start at 9 o'clock because 9 to 12 is the area which is going to be a little difficult technically. If you're beginning, then probably you will feel that difference. If you're starting at 9, your belt loop or the counter traction should come at the opposite side. That becomes a 3 o'clock on this side. Right? So when I start this, I'll ask Dr. Ritu and Dr. Nupur to actually keep constant pressure balanced on the first string endoscope, not too much, not too less. But in between, when I'm removing this, then Dr. Nupur has to stabilize the CAD so that it doesn't slip out and change our orientation. So now, Dr. Ritu, please let go. So we are starting here at 9 o'clock. Important thing, yet again, is, first stitch. Do you have an inside view? Is it good enough?
Yeah,
Yes,
we can see
right.
Nitish.
Yeah.
Nitish, but I want to ask you a question. Normally, Longo had advised that 2 stitches to be taken at 9 o'clock and 3 o'clock as a holding stitch. Do you do that?
Ma'am, I'm starting at 9 o'clock and I will be having a holding stitch at 3 o'clock.
Okay.
So, because I think the original description is, it does not mention about taking a counter stitch there. Now there is a technique to take this particular stitch. You go with the tip of the needle, rotate it in such a way that you should be able to lift the mucosa. At the same time, there should not be puckering and you should not see the blue of the thread. So once it goes through, it should get lifted off the wall like this. So this particular thing, it becomes important for you so that you can follow in the same plane. And when you're doing this, you don't need any assistance to actually guide the thread. It is the surgeon's hand which will keep on understanding by getting the feel of the tissue there, that if you feel that there is a lot of grit there, that means you have gone inside the uh,
I may be wrongly informed, but
muscle, but otherwise it comes off easily. I said easily, and my first needle only has got stuck, so no worries. We'll just take it, try this, and go ahead with the procedure again. So every single time when I take a stitch, I have to make sure that I am not locking it. And the moment I take stitches and I want to shift to the other side, these people have to stabilize the scope or the CAD in such a way that I get the next thing. So little bit of bleeding there. Sometimes you get a hematoma. If you get hematoma, you need to stop operating, keep pressure on that area, let the hematoma subside, and then only go ahead. Otherwise, you will end up taking a very superficial stitch, and that will give you incomplete donut or a lot of bleeding at the end of the procedure. So these are the two things which you have to keep in mind. Sometimes if there is a large piles, you may decide to go through the hemorrhoid, which is called as the U modification of MIPH, where we are doing partly the hemorrhoidectomy rather than hemorrhoidopexy, as the name suggests. So again, if the buttocks are heavy, you can just squeeze them out like this so that you maintain equal distance from the dentate line. So fine. So I'll keep on going like this. So this is, I don't know if you have a good view inside. If not, then please let us know. We will readjust and we'll just keep on shifting from
Nitesh, camera
quadrant to
need to be
quadrant.
readjusted.
Sorry?
Camera need to be readjusted.
Yes,
So that
please
we
readjust
can
the
have a good,
camera.
yeah, we can have a better view from inside.
Right. Now that is very important, and I think if you want me to move on one side in order to
He's
give
still
you
on
a
the
good
same
view,
side.
I'll do that. So fine. Again, see,
We are not able to see what actually where you are taking the stitch.
all right.
Yes. Okay.
Ask the cameraman to
Camera
keep a little more
person,
parallel to the
can
anal
you
canal.
you just come right behind my right shoulder, and if you want me to move my head on one side, I will happily do it. Fine. So see, we are reaching at around 3 o'clock now. So that is the time when I have to take the belt loop or the counter stitch. Now, when you are starting doing these procedures, sometimes this very simple maneuver can be very challenging. So if you have a loop which is already placed like this, all you have to do is just go through this. Take the needle through the loop and go ahead with your business like the way you were doing earlier, rather than worrying about where the suture is going, how much deep you are, and you can take the next bite. Okay? So, anyways, we'll just rotate it a bit. Nupur, just hold it. Yes, please. Thank you. So, after we do that, you're pulling too many things. Please don't do it. Let go. Yeah, thank you. So, no, even I can't see. I don't know how they can see there. Fine. All right. Can you see that now? You have a good vision?
Yes.
Yes, we can
Yes.
see.
So the thing is that your exit point is the entry point for the next suture. And avoid the temptation of going too deep in loose mucosas like this. Definitely this helps in prolapse or correcting the prolapse a lot. In fact, if you have a mucosal prolapse which is around 2 centimeter, you can easily tackle it with the stapling device only. So this particular thing has to move out, then you go inside, fix it again. And like you can see me squeezing the buttocks all the time so that I remain at the same level. Can somebody adjust the light, please? And sister, some open gauze pieces here. It's a good practice to keep some gauze here so that you can clean it repeatedly. Usually the mops will not help much in this area. And again, I'm taking advantage of that loose mucosa. In between, if I need to, I will just keep on adjusting my suture line a little bit above and down, depending on the prolapse which I see. If the prolapse is more, I'll bring the suture line more down towards the dentate line.
Hello.
Yes.
Dr. Mittal sir is ready. Can we shift the audio to him, sir?
Yeah, please go ahead.
Thank you.
Yeah.
Mithal sir, please start.
Sure, sure.
No.
This is a 21-year-old male patient with MRD 272036 diagnosed with pilonidal sinus. He came with the complaints of pain in the natal cleft region since 1 month with opening, has a past history of Crigler-Najjar disease. On examination, there was an opening in natal cleft. On investigation, CT sinogram suggestive of pilonidal sinus tract extending from the gluteal region at S3, S4 level with a blind end in the rectococcygeal region. No evidence of communication with sacrum and coccyx.
Hello.
Yes, we can hear you. Kushal.
Okay, you can hear me, right?
Hmm.
Can you hear me in the hall?
Yeah, we can hear you. Can
Okay.
you show the external view of the patient?
Okay, the patient is in prone position. The buttocks are strapped. You can see the strappings, and no pillow is required underneath.
Okay.
This is what we call as he's had an abscess and it's drained. We should not impart or go in for major flap surgeries in a minimally infected pilonidal sinus region. Now, when I first saw this patient, everyone suggested the opening was here, right? No, this is not the opening. It's here. This is the opening. How do we know? We took a photograph with a mobile and enlarged it. Then we see the openings are here. There are two small openings, and this area seems to go down. I think they did an MRI. It's saying that the tract is going backwards. So what I'm going to do, people are going to ask me later on, can you do this under local? Yes, you can do this case under local anesthesia. And what you do, I'm going to show you the staining and how local is to be given in case of minimally invasive surgery, even laser in pilonidal sinus. So the area I'm going to give local to is like this, like a box. You can see that. And the area other I will give is around this place, going deep. Ideally, if the patient is the undershot GA, I would give Xalocaine, adrenaline, that's all. I don't need to add bupivacaine. But if the patient is under spinal, then instead of lidocaine with adrenaline, I use saline adrenaline. How do we prepare this saline? 100 ml of saline bottle, add 1 ampule of adrenaline, that's your solution. And that's what you can inject so that there is no bleeding or less bleeding. Now I'm going to take this all away. What I'm going to give is modified saline adrenaline. That means I'm going to inject it here because once we cut, it's going to bleed. This area is vascular in the sense it bleeds a lot.
Sanjay, I think let this MIPH he's waiting.
Yes, Nitish, what are you doing? Can you come up?
So 1 second, you're not audible.
You
Please,
can take the
we get
mic to Nitish.
Can we get the audio to Dr. Nitish, please?
You can't do it. Yeah,
Yeah, please do it. Mithal sir said yes, please.
Yes, you can shift the
No
audio.
problem. Let her. Yeah, am I audible now? Yes.
Yeah.
So now what? In the meantime, when I had time, I have just packed it so that there is no edema in that or congestion in the hemorrhoidal tissue there. What the next step is to fire the stapler. Now, before we do that, we have made sure that the busting is complete. We have taken the belt loop at around 3 o'clock. 9 o'clock we started. We, overrun the entry point. So I have just passed the entry point by taking a busting suture little beyond that. Now, next step is to make sure which stapler you are using. One, usually we use a 34-1. I these days prefer using a 3-row, which gives you a better hemostasis, but 2-row is equally good. These are the marks which gives you the distance from the anal verge. When you close the stapler, you should either just see a part of this pore mark, or you should not see this at all. It should go inside. That is one. You open the stapler fully so that you are able to go beyond the busting suture. Then this window will tell us where we are going to fire. Once it comes in the green zone, then the stapler closing comes to the ideal form of B, which these staples form. This is the lock which should go off only once. because you are supposed to fire only once. If you fire twice, you will staple once, but you will cut twice, and then there will be torrential bleeding. So you open this once, fire, and close this. That's all. This is the knob which helps you closing and opening the stapler. We'll talk about this when I actually do it here. So now what I have to do is I need to remove this, remove pustering endoscope, direct it towards the sacral hollow and nose of the patient so that I remain in the midline and little bit down. I'll get a feel of give when I go inside, and that is where I know that I have gone beyond the pustering. And when we were
Nitish, tell the audience if it's a female patient, what extra step you will take.
Yes, so we need to be careful that we should not take the posterior wall of the vagina. So when I close the stapler, I'll try to lift the posterior vaginal wall by using a tooth forceps, one. And secondly, while taking the suture, I will be extra cautious, not going too deep here. In the meantime, when we were not, when I was not talking to you, Ritu, you need to support this. Let's leave rest of things now. Support with proper this thing. Fine. So now I have gone beyond this point, and what I need to do is belt tube is already fixed in its position, and now I am taking control of both the ends of the pustering suture. So what we need to do is avoid, just 1 minute, ma'am. Can you just hold this? So this is the pustering and this is the counter stitch there. So what I need to do now is to try and tighten the pustering. Now it is a monofilament suture which we have used. If you do a motion like this, the movement like this, that you're pulling one end, the other end should go in freely. So you make sure that you have not locked the suture in between. When you do this, there is no undue pressure on you to tighten the knot in such a way that there should not be a loose donut. So I keep it almost of equal length on both the sides. Once I have done this pulling and pushing movement, as you saw me doing this, afterwards I take a single knot. Now when I take this knot, make sure you guide it with your finger, and there should be enough space for you to go inside. If you find that the space is too less, that means there is something wrong. Either you have not gone at the correct distance from the dentate line, or there is some other issue. So single knots, you keep on pushing. You can take 2, 3, whatever suits you. Give me a suture threader. Now there are 2 windows which are, or rather 4 windows which are provided on this side. You need to railroad this thing through this. A good practice is to go across, cross this and pull it out. The moment you come out, just a mosquito please. You need to fix it with a mosquito. That makes your job a little easier. There is no chance of losing it in the bargain. Now little careful on the belt loop side, because we have not tied the knot here. So accidentally, if you pull only one end of this belt loop, the whole thing will come out, and that will beat the purpose. And at this point, you won't be able to go in and take a belt loop again. Now there may be a logical question: what if it comes out accidentally? Answer is don't do anything. Go ahead and do the procedure as you like. The second thing is to hold the stapler in this particular manner. My middle finger is in the loop which I have created by holding the sutures like this. If I want, I can go little closer, because as I close, this may come little close to my thumb. The thumb is at the locking position or the lock. I am directing it towards the sacral hollow, and then I start closing the stapler.
Auditorium.
Let him fire the staple, then we'll shift to the other side.
Hello.
Hello.
Sir, Mittal sir is ready for surgery.
Yes, just 1 minute. Dr. Mittal, hold for a minute.
Okay.
Let him fire the stapler, then we'll go to you.
Sister, give me a gauze like this with jelly. So now you can see I have closed the stapler, and you can see the number 4 disappearing in that circular anal dilator. Is it visible to you there? And this has come in the firing zone. This particular orangish mark is in the firing zone. We are at the perfect B. It is at the 4 point. I'm still maintaining the traction. I'm waiting for the fluid to move out of the donut which I have already taken in my stapling device. Wait for 30 to 60 seconds here. 30 seconds is recommended in all types of staplers. So whether you're doing here or in GI tract, this is the principle which we follow. Now I'll try and tighten it a little more. Now, once we have waited and done this procedure, I really can't tighten it more than that. Even if you are very strong, you're a regular gym goer, please don't try to overdo this. You may break the knob. Once it is in the firing zone,
Nitish,
you
would
have
you
no
be a bit,
business closing it
hello,
even more.
Nitish?
Yes, ma'am.
Would you be a bit fast because Kushal
Yes,
is
yes.
meeting?
Yeah, no problem. I'm just firing. Just take these instruments, otherwise I'll miss my chance. Okay, so now this thing, while firing the stapler, it is a good practice that you do it in a stand. Sister, give me a mosquito, please. You do it in a standing position, because if you want to do it in a sitting one, you may not be able to generate so much pressure to close this. Most of these staplers, they have a feedback. You will hear a click when I fire this, and this is how it fires. Afterwards, just let go, lock it in one attempt only, no further firing. So once you lock it, even accidentally, you won't be able to do it. Now, the second thing
Kindly
is to open
audio
this.
of Dr. Kushal Mittal, sir.
Okay, so I'm not audible anymore, right? Yeah, I'm still audible. So I'm opening it by 270 degrees. Then you rotate the stapler on both the sides. Dr. Nupur and Ritu, they are
We
holding the
go to
CAD,
Dr.
and I
Kushal.
just come out with a fishing movement and then immediately pack
Audio to
the
Dr. Kushal
cavity.
Mittal Theatre.
Fine. So we just have to show them the donut, and that's it.
Kindly shift the audio to Dr. Mittal's OT.
Yes. So this is the donut. Once we show this, I think this completes the procedure. And this is a complete donut. You can see the distance. We have measured it, and there is no perirectal fat in this. This is a reasonably long one, so that it shows that the prolapse was little more at the 11 o'clock, so that we have taken care of this, and the donut is complete on all sides. So this pretty much finishes the procedure. What remains now is to take
Shift
the
the audio to Dr. Mittal's
Sir,
OT,
Doctor,
please.
sir,
We want to show
we are
the
shifting audio to
suture line.
OT to Doctor
Fasting anoscope.
Dr. Kushal
Yes,
Mittal,
Dr.
sir.
Kushal, we are
Yes,
ready.
Dr. Kushal, we are with you now.
Okay. Sanjay, you're there. So any questions regarding the instruments, you can tell them. This is the Store's waft scope. It's 3.3 millimeters at the tip. It's 3.3 millimeters
yes.
at the tip. It's got a working channel of 2 millimeters through which your forceps and your
in BPH
for
there is a
cautery
bleeding.
and
Let us see
for
how the
brushing can be
bleeding
put
is
in.
being handled.
You can see that.
And
You can see
the
screen is open.
instrument is for pinidal sinus. You may have to take out the handle, because if it goes too low, then you have to take it out. Otherwise, you use it. Irrigation, since I'm not going to do cautery in it, I'm going to do laser in it. I'm going to be using saline, and it's best if you use a TUR set, because IV sets are very slow irrigating. And that's how the कहाँ से बंद किया? That's the flow. Now here posteriorly वो दूसरा चाहिए, metal. Stores वाले नहीं आए. इसके पीछे वो three-way metal नहीं है उसके पास. Okay, now I'm going to show you the wound. Okay, gauge.
Yes. You can see a small bleeding on the MIPH case, and he is taking the figure of 8 suture.
Okay.
You can observe on the screen on your left.
Now, methylene blue, sister is going to give me. So how do you mark out? These are punches available on Amazon, and they cost, a set of 5 punches will cost you 300 to 350 rupees. They are single use. What you do is you take methylene blue in a bowl, you dip it, jerk it, and here, pakdo. And I'm going to mark the opening. Okay, and then clean it. I have to see, does it cover? So I am going to make a punch here. The punch is complete. I take it out and lift it, clean it. You take this disc out from the base. Okay, now that's what comes out because I punched it. Now with a mosquito, I'm going to go in and see what's inside. Unhealthy tissue, hairs I have not got yet.
So you can observe Dr. Mittal is now removing the epithelialized part of the tract, the so-called pit, which is communicating with the underlying sinus cavity. The skin is communicating through
Give
these
me a
tracts.
gauge piece. Okay, then I put in a curate. I'm doing this step first to show that people who are doing just lasers, what if you miss something? I don't think we'll miss anything, but still, now this is a hair. So I'm taking, दिखाओ ना इसको, strangulate मत करो. So I'm going to first make sure there are no hairs. Then I'm going to put the scope inside.
Dr. Mittal is doing this step to tell you that what is the advantage of doing the scopy. That is the under vision guarantee of removal of hair.
Now we are going to start the irrigation and put the scope inside.
Yes.
Suction. So can you see the scope view?
Yes.
Sanjay, can you see the scope?
Yes, yes, we can see the scope view.
Okay, so what I'm looking for is...
outside. Yes, now it is the inside view we can see. And we have a picture in picture. No problem.
You have to do here, lowest part. So basically what I'm looking for is even a single strand of hair, and on which wall is the unhealthy tissue. Okay, so we didn't get anything, but last week we did a case in which the sinus looked, there's nothing there, we curated, took everything out. The moment we put a scope in, there was a balled out, on the left margin there was a balled out bunch of hairs. So if those hairs don't come out, then it's going to be a problem. Now I'm going to curate it once again. Chashma deo, laser ka.
Kushal?
And you don't have a WAF set, it's okay. Use any set which is 3 to 5 millimeters in size but has a working channel for irrigation and putting instruments. Now how do we put an instrument through this? Wo deo, grasper. If it's small, hold here and hold here. Close. Now see how the sister's introducing it. Okay, that's the grasper, it comes out. The grasper, if I have anything inside, I'm just showing it for demonstration. Ye saline bottle pe pressure dena. Okay, you need more pressure because with the grasper the working channel becomes smaller and the irrigation becomes less. So if there's nothing there, don't do it unnecessarily. I'm just digging in to see if there's any hair anywhere. No. Unnecessarily do not keep exploring. Okay. Now we are going to take the laser fiber. देखो radial fiber किधर है?
If it is a long cavity, it is advisable to do the scopy from both the sides. Dr. Mittal, tell them the importance of that.
Okay, something beautiful about this radial fiber. Can you see? This is an infinite fiber. Huh? Infinite ring fiber. So it's got 4 rings. Instead of 1 ring, it's got 4 rings. So that means uniformly is going to do it. Now we're going to introduce this. My foot switch, I had kept it locked like this. Open it. चश्मा सिस्टर को नहीं बनाया. एनेस्थेटिस्ट कौन है? इनको बनाओ. So this step is important. Please get everybody in the OT to wear it, including the anesthetist, because if my fiber comes out and you're standing there, it's going to hit you. Not this one, this is go rubber pen lo. Okay, who is with the camera? Chandrakant, Chandresh. Yes, chalo. The fiber, inserting the fiber inside, cleaning it. Next, suction, dur karo. Okay, ready? Gauge piece. हाँ, on करो. Sister gauge. Sister gauge. So what I advise is, in order to tract, touch everything, ये हटाओ, wound उसमें आ रहा है. Press on the gauge. 10 to 12 watts. Yes, patient को shivering है. Okay, 10 to 12 watts millimeter per second withdrawal. So I'm just waiting. Patient is having a little shivering. So don't be in a hurry to take it out. It's 1 millimeter per second. This tract is, I think, about 2 centimeters, 1.5, 2 centimeters. That's 15 to 20 seconds. Machine ka view aa raha hai. Okay. So I'm out. I take my irrigation cannula. I mean, routinely, if you're not doing, if you don't have this instrument, now I'm irrigating it. See inside how nicely it's burnt. Now sometimes once you burn it,
we are not getting the inside view.
Inside view, please. Can you see? ये बाल लग रहा है क्या? नहीं.
Yes, now we can see the inside view.
ये hairs ये exit पे ही है. नहीं अंदर है.
Sir, one question.
ये देखो hairs दिख रहे हैं?
Hello, sir.
Yes.
Okay.
Please ask, can we insert this laser fiber through the scope?
Yes,
Is
we
the
can.
diameter of scope?
We
Yes,
can.
yes, you can.
देखो Naresh, the reason I didn't show that is I wanted to show people with laser how they do it. More people have laser than waft. Yes, I do that. How do I do that later? First I do this, and whatever hair skip areas are left, I do it. Now, for
It's a fast.
sister दो हाथ इसको पकड़ो.
Yes, that's the
sister
problem.
clip लगाओ. Okay, now I think 2 hairs have come after burning. Let's see.
Kushal, can I interrupt you?
Uh,
As per MCI guidelines, I think the moderator will answer your question. So Dr. Sanjay is answering your
Okay,
question.
okay. I'm just saying I've got the scope inside and I'm looking for hairs. I think this is a hair. I'm going to come here and take it out.
Yes, you can use the scope, no problem. As he already told you, he is demonstrating those who don't have the scope. But it's advisable in the modern practice to have the scope so that you can remove every bit of granulation
So I'm
tissue as
taking
well as
out-
the hair under guarantee of the vision. That's the advantage of the scope.
That's small hairs which came
Singh.
out after I had.
Dr. Singla,
Yes.
can we use
So-
a cystoscope or hysteroscope just to look at the cavity?
Earlier people used hysteroscope, but this scope is very sturdy. It doesn't bend, it doesn't break that way. But the other scopes are fragile in that regard. Number two, the hysteroscope, that cystoscope is a rod and lens system. The chances of damage are more. These are actually, they are rigid, but they are fiber optic scopes. That's why you can see small impression like a thumb impression.
You
can
see
over
how
the
to
screen.
take it
I'm
out like
talking
that.
about those who don't have a fistuloscope.
They should purchase.
Okay.
No. Accurate.
As you saw Dr. Nitish Jhamar being operating the case
Accurate
of
और दिवस से बड़ा.
we all have seen a small complication like bleeding. So MIPHs can also have
इस पर
some bleeding
size
sometimes,
millimeter
which is been
length
tackled
के
by
ऊपर है.
pressure and
Okay.
stitches.
So 12 watts per millimeter.
Dr. Singla,
नहीं,
Yes.
basically, I
even
know
for
you
fistula, it is not
doing
limited.
the WAF,
Limit is
but the main
in fissure
pathogenesis of
and
the
hemorrhoids.
cleft,
Can we
the pyramidal.
can we have audio in OT1? Dr.
Nahin.
Nitish is injecting
Irrigation.
methylene blue, and you'd just like to.
Yeah.
Any questions for Dr. Nitish Jhamar from the audience? For MIPH?
So just for the sake of audience, just want to know how he managed to tackle the bleeding.
Okay, I'll just pass that on to Dr.
So
Nitish.
he managed with number one, with resilience and perseverance. He washed every bleeding point, then did a suture with a Vicryl 8 shape suture. He took all the bleeding points over the suture line, and that's how he could control. The message is you control it with sutures. Don't try to apply
Dr.
any
Nitish
sort of
has audio
electrical
now.
energy, because there are already clips, metallic clips are there. So don't try to use any electrical energy or any bipolar or something like that. Always apply sutures.
Dr. Nitish sir, audio is already on.
Yes.
He
So
wants to
now,
give-
see, you. I think I'm glad that there was bleeding when we did that, and that is why initially I was telling you, if you use a triple row stapler, the chances of bleeding goes down. Now, second thing, which Dr. Shingla sir pointed out very rightly, you need to be very patient. Don't worry. Even if you are operating in a conference, you need to don't try to look good. You have to give enough time to locate the bleeding point. Now, if the bleeding point is from the staple line, you have to take a figure of 8 stitch. Yeah. Yes, control. So, you have to take a figure of 8 stitch covering the staple line. So, take the stitch above and below and close this. If the bleeding is coming from below the staple line, then you just need to pack and wait for some time. Mostly it stops. Now, we use a 2-0 to control the suture line bleeding or a staple line bleeding, but if it is from below, if you use a 3-0, that will be better. Examine it quadrant wise. Don't remove this CAD till you have finished the whole thing. And in MIPH especially, it is important to have an impeccable bleeding control on table, because post-op, if you get this bleeding, this can be torrential. So this is one of the things that you can have an incomplete donut, you can have the bleeding. These are the two common complications. You can tackle both by taking figure of 8 stitches.
Thank you, Nitish.
So,
thank you.
thank you, Nitish.
Thank you for the good presentation.
That is why he has shown that he has kept the CAD till the end.
Yeah.
Some people remove
Auditorium.
the CAD when they remove the stapler out, but he has kept the CAD till the end, and that is the advantage that you can
Hello.
see the any bleeding and the things.
Auditorium.
We shift to the Dr. Kushal Mittal's OT.
Yeah.
Kindly shift the audio to Dr. Kushal Mittal's OT.
Sir, a question. Where should the methylene blue be injected, in the circumferential pattern where sir told, or at the stapler line? There are two consensus. What is your opinion on that?
There is no need to put the methylene blue at the staple line, because that is above the dentate line. He has just put the methylene blue where he has taken the stitches to decrease the pain. That's all.
So only to decrease the pain of this sutures, or
Only sutures.
cat sutures?
Well, some people they use the methylene blue in a block to decrease the pain.
अरे वो कौन बात खत्म नहीं होगा, वो चलता रहेगा.
He gave a put in
Hello.
the block.
Sir, Dr. Mittal wants to point some points.
Yeah. Those who are doing laser, remember,
Parvez wants to
curate. Can you hear me?
He's just saying something.
Yes, Dr. Parvez, we will take your point little after, and Dr. Mittal is going to tell us something about the laser. Yes, continue, Mittal.
Okay, can you hear me?
Yes.
Okay. When you do pyramidal sinus by laser, first curate, then laser, then curate, then laser, then curate. You start with curate, you finish with curate and do laser twice. What I've seen is people do curate, laser, and that's it. And these patients have recurrence.